percentage uptake in endemic regions?
Excellent. But there's actually consideration of changing the name of nuclear medicine as a result of that. Wanted to kind of change the subject from showing the added value of PET-CT in a particular type of cancer to just share with you my thoughts about some of the potential sources of false positive in reading head and neck studies. We know that PET-CT changed a lot in terms of the initial staging, the diagnosis, follow-up, assessing responsive therapy in head and neck cancer cases. This particular study showed that PET-CT has, as FPG PET-CT has a sensitivity of 89% and specificity of 95% in those patients. Show an example from our cases. This is a 48-year-old male with squamous cell carcinoma, as is the case in most of the head and neck cancer cases. PET-CT was done for staging. As you can see from the dates, it was September of '04. You can see that there is a lesion at the floor of the mouth on the left side, and then there's a large FPG avid node that is just medial to the left aesthetically domestic, consistent with nodal disease. Patient received chemotherapy and radiation, and the standard now is for these patients to receive chemo and radiation, and if the follow-up is negative, then there's no need for surgical resection. If it is positive, then they intervene with surgical resection. In following up of the chemo and radiation, you can see that there's no lesions in the head and neck area. However, the CT showed that the wax is suspicious for malignancy. And here's the transaxial cut showing the CT. That's the problem in CT, that basically it's all blending in. So if there's a lesion within this area, CT will be able to characterize this. But by PET, you can see it's mild, increased uptake, consistent with the benign disease. 3 months later, patient had a selective level 2, 3, 4 left neck dissection, and the PET-CT was done for restaging. You can see that at the floor of the mouth, there was a new lesion, and there's a little bit of misfusion here. So PET-CT, even though it's a sequential image acquisition, you can have a few seconds difference between the PET and the CT image acquisition that can lead to a problem with the registration of the PET and the CT together, and you have to factor this in when you're reading the study. So actually, even though this is projecting kind of midline-ish or even to the right side, if you factor this in, which we did at the time of reading the scan, and you can manually switch the PET and the CT to fuse them together, and this will project in the left floor of the mouth. So that's where we pulled it, and they went after it by biopsy, and it came back negative. So the question of whether it's a false positive by us or it's an issue of biopsy. But that's the nice thing about the continuity in care of patients. So they repeated the PET scan 3 months later, and now we see that the lesion is truly in the left side, not the right side, and now there's a nodal disease. So we've actually, in my center, we're doing a lot of head and neck cancer cases, so we're learning a lot about it. Another advantage in PET-CT is that we're looking at the whole body. So it's the head and neck cases, the standard of care, the textbook is local exam and maybe just X-ray or just CT, but they're not looking for the rest of the body. This patient has right orbital melanoma and inoculation, and that's why you can see the right eye here in December of '06. And then the CT showed something suspicious in that area, and then also the CT brain did the same thing, and the MRI showed the same thing. But everyone is imaging that head and neck area. Here's the rest of the body. So it is unquestionable that in these cases you'll save a lot of money and time if you do look at the whole body than if you have just evaluation of the primary. And that's the problem in medicine, that every physician is thinking just in their specialty and not really thinking that cancer is a systemic disease. Also, head and neck is a frequently site for a patient presenting with a cancer of unknown origin. This particular study, which Dr. Hammond also worked with us at St. Louis University, presented it at the Study of Nuclear Medicine last year. And this is one of the cases that we presented. A classic case in the head and neck area. 51-year-old male, right neck mass, biopsy of which revealed metastatic squamous cell carcinoma. Here is the lesion in the right neck. However, the CT, neck CT with contrast showed the neck mass without evidence of a primary. But you can see in the head that there is some asymmetry in the right tonsil compared to the contralateral presumed normal left side. This was a biopsy-proven right tonsillar cancer, and that's frequently the tonsil is the most common primary in these cases, presenting with the head and neck cancers. So in this particular study, we showed that PET-CT plays a major role in identifying the primary in over half of the cases. The problem in reading head and neck cases is that it's a very complicated anatomy. That's why it's a subspecialty in CT. Neuroradiology is a whole different specialty. And then you have also a lot of distracting physiologic information in the head and neck area. A lot of the lymphoid tissues are lighting up, and they vary by age. So I'm sure in the pediatric population, they look different than in the adult population. And then more complicating even, the fact is that once the patient has surgical resection, then you lose symmetry. When they come to you and half of their face is gone, then suddenly you have stuff lining up on the other side, and you don't know whether is that benign or malignant because you have no normal site to compare it to. This particular study was published in Radiology back in 2005, just describing all the normal physiologic uptake in the head and neck area. Because in our specialty, you have to know physiologic distribution, because without knowing the physiology, you're not going to be able to identify pathology. So these are all regular, normal structures in the head and neck area that typically will light up, whether it's a soft palate, lingual tonsils, pharyngeal tonsils, submandibular glands, vocal cords, parotid glands, palatine tonsils, and sublingual glands. We recently published this particular paper, from which most of the cases I'm going to show you today are coming directly from this paper, trying to make an atlas of the non-malignant causes to increase FDG uptake, not focusing on normal glands, but on pathology, but a non-malignant pathology that may cause increased FDG uptake, and without this knowledge, you may overflow the study. So as far as physiologic, we're not going to get into every single structure, but this is actually a normal volunteer. So in particular, what I believe was a unique study that we did 20 normal volunteers, no history of cancer. A lot of what we are presuming normal, we're taking someone, for example, with a head and neck cancer, judging their bowel and saying this is normal. Taking someone with colon cancer, judging the head and neck and saying this is normal. But it's a quasi-normal, it's not a real normal. Normal is not normal unless you look at someone with no history of cancer, because you can argue that cancer and or its therapy may change systematically the distribution of FDG in the body. So we did 20 patients, and I can tell you it was a wealth of research opportunity for us, because every single abnormality that we saw in something else, we compared it to the normal in those patients, in those normal volunteers. External ear and nasal and nasopharyngeal uptake, that is normal, and it can be quite variable. As you can see here in the PET-CT fused images, and clearly if someone has had an infection there, it will be more intense. Thyroid uptake is quite variable. When it's symmetrical like that, we brush it off as a normal uptake in the thyroid. However, I'll show you some examples where it can be asymmetrical and focal uptake. Typically, that's benign. Sometimes when it's symmetrical and intense, it could be indicative of underlying thyroid disease, such as thyroiditis, Hashimoto's disease, but we don't worry about it as being cancer unless it's a focal, intense, and asymmetrical. Parotid gland can be very mild, like this one, or can be intense, like this one in another patient. And people try to make sense of why the parotid glands are lining up in some patients with another, and make a relationship between this and age, but nothing that's really solid. So for whatever reasons, it's kind of variable. But luckily, it's very, very rare to see cancer in that gland. As long as it's symmetrical, you're fine. And if it's not symmetrical because this side is gone from surgery, then you kind of have to use your imagination, and that's the importance of also having a baseline study in some of these cases. Submandibular gland can be asymmetric. This patient had no surgical resection to explain this asymmetry, and we didn't see any evidence of dental infection to explain why the right side. But it's very common for clinical or subclinical infection in the oral cavity that you can have asymmetrical uptake in the submandibular gland. Larynx can be quite variable. You can have intense degrees of uptake like this, whether it is from radiation or from a patient talking during the uptake phase. Or if we speak excessively before even the injection, it may propagate to during the uptake time. So a lot of what we see sometimes may not be related to what the patients are doing during the uptake time, but actually more to what they are doing the morning of the exam. So we try to pull them the day before part of the preparation, in addition to asking about the obvious diabetes, blood glucose level, claustrophobia. We also try to advise them to not to exert a lot of muscle efforts, and that's it. That is what this is the same exact patient in 6 months earlier, and there was no intervening therapy. So even within the patient, you can have a great deal of variability from one study to another. Posterior larynx, that also can light up because of the arytenoid muscle. You can see again. Luckily, in these cases, your job is easier when it is symmetrical, like that and bilateral. Here's the arytenoid cartilage lighting up. Typically, when it's benign, it tends to be mild to moderate. Not to say that you're not going to see intense, but definitely it's mild to moderate. That's more likely to be benign than intense. This is the anterior larynx uptake in a 71-year-old female. Again, normal variant hypermetabolism. All of these patients, we either followed them long enough to know that this is benign, or when we're suspicious, we had actual pathology at the time of submitting this paper. Muscles, quite interesting. I'm always fascinated by the degree of muscle uptake. And you can, it's almost police work trying to figure out what was the patient doing during the uptake phase to cause that unique muscle uptake. So you can have the left temporalis lighting up here. This patient was nervous and clenching a lot. If you put your hand and you clench, you're going to feel the temporalis contracting. That's what you're looking at. This massive that patient was able to escape the gum, and he was chewing the gum on that side, causing the massive to lighting up. This one is easy. This is a vocal cord lighting up, patient talking. You can have asymmetrical uptake in the sternocleidomastoid area, as you see here. Intercostal muscles and the scalene muscles are lighting up more intensely if there is a COPD. We had a research study that we were correlating the degree of uptake in the diaphragm, intercostal muscle, and scalene to the pulmonary function test in those patients with COPD. And then from what we learned from this particular research is that if you see scalene muscle lining up, that's a severe COPD in someone. That correlated perfectly. But certainly if you have the diaphragm, see here hyperinflated lungs, you can see the intercostal lining up as well as the scalene, and then the diaphragm. This other different patient that also had coughing, so you can have a lot of abdominal muscle uptake. Sternocleidomastoid bilaterally lighting up, posterior muscles of the neck, our spinal area. I'm not going to focus on the others since that's not a head and neck area. You can have interesting cases where the muscles are lighting up. This particular patient can see the forearm, the hand, more on the right than the left. See the hand muscle here? What's interesting is more of the legs, more on the right than the left. So kind of, I said, tell me what was the patient doing in the uptake phase. And this is what the patient did. She had this cute little toy that she was working with. You can see the amount of effort that we put in some of these games, and more on the right because she's more right dominant. This is during as a result of food intake. If someone is eating, or you get to either external insulin by injection, or if someone is eating, there is internal insulin that gets released and it drives a lot of the FDG to muscle. And that's what happens. You can have diffuse muscle uptake like that. That's very difficult to identify, especially if the patient has subcutaneous lesion or melanoma case. And also if they're using a lot of their chewing, then you can have a lot of the muscle uptake in the tongue, which makes it more difficult to evaluate the head and neck area. This particular patient was a very interesting case because the patient had schizophrenia, and she, I don't remember here, was taking antipsychotic, and it's a side effect to have the thyroid dyskinesia, which there's tremors. in the floor of the mouth and in the tongue. And that's why this is lining up. So certainly, when we hold it as positive in someone with history of head and neck cancer, then digging through the history, we saw that this has clinically, the patient has known twitching in the tongue area, in the mouth area, and that caused the increase of uptake. That's why it's very risky to read these studies without getting a detailed history. And it's a problem here, I know, from the days of residency, that you try to get history from a patient and you can't. And I was talking to one of the colleagues here, people tend to say, don't talk to the patient about their cancer, so it even complicates things in taking decent history. But it can change completely the rate from this being highly suspicious for cancer to this is just a normal physiological uptake consistent with the patient known history of tongue twitching. Labor breathing, we already covered that. The longus capitis muscle is very interesting because this is the same patient. Here is at baseline, and this is 3 months later in follow-up, and you can see it's lighting up. Now, why it lights up in one study but not the other, I'm not sure. I don't have an answer for you. We don't know why, but I think this is an area that's frequently very stressed, or you have a lot of contraction in this area and neck pain, and my guessing is that it has a lot to do with that. And if you are carrying the weight of your head differently, it may be the explanation. And we are going to design a detailed questionnaire asking patients different questions, trying to make a connection of what we are seeing and the symptoms the patient has, because I think it will be very helpful, not only in minimizing false positive, but also it may guide therapy. If someone is saying so it's not in their head, but they're having neck pain, we actually have a solid evidence. Because if you see here MRI, it's going to be totally negative in these patients. Brown fat, that's old news, has been described before, and the supraclav area is the most commonly seen area for this just because of high, large area of brown fat, and the head and neck is no exception. Non-every patient will present with the classic pars line of the supraclav and how we use this brown fat. But these cases are challenging also because it's no longer a potential source for false positive, but it's worrisome that it is a potential source for false negative, because if there's a lymph node lighting up within this area, it's very easy to miss it because it's going to be in the sea of this intensive phase uptake from brown fat. And that's why, particularly in the pediatric population and in older season, you can see more of that, and we routinely, and this would be my recommendation for the head CT centers to use warm blanket, because that cuts it down dramatically using warm blanket. During the uptake phase, and we tell the patient to stay for the day. Inflammation and infection is probably the most common source for false positive in the head and neck area. This area is just full of infection and inflammation that will light up and look like cancer. Nasal uptake, I can tell you that I've seen a lot of cases where the nose lighting up and someone has a history of melanoma and they send them to have a biopsy and it comes back and it's negative. Someone told me that actually the stock is to have 3 biopsies of the nose. It's very unfortunate because this is a normal, particularly if the patient has a little bit of a runny nose during the allergy season. We actually did a study where we correlated the degree of uptake in the nose and the CDC record of influenza and cold during the cold season, and it correlated very nicely that we see more uptake in the nose during that colder season with any, just because it's a very sensitive to this area. Sinusitis, very common. You see here fluid collection in the left, so there's sinus. And when it is chronic, it will have mild increase of ache. When it is acute, it will be significantly more intense than that. This patient had a history of left head and neck cancer, for which he had lumpectomy and prosthesis put there, and there is some reactive change to the prosthesis that you are looking at here. So again, it's not uncommon when they remove part of the mandible to take a piece of the bone from somewhere else and they put it there. Dental disease is very common, and dental disease is very common false positive. And a lot of these patients, if they're going to have radiation therapy, they take out all their tooth because they're going to lose a lot of it because of radiation therapy anyway. But it's not uncommon to have focal intense uptake in this area that perfectly correlates with the patient's history. And now we're trying to get reports on the dental hygienist who's examining these patients at the time of reading the PET scan and head and neck area to correlate both together. Teflon injection, this has been published before, that because of the granuloma formation on the macrophages will cause intense, as you can see, again, as Dr. Pan said, if you use SUV, it will be totally wrong in these cases, and I've seen cases where this was called right local cord cancer, for example, when in reality, if you know the history, that the patient has a Teflon injection, and this can persist for many, many years, without the patient being symptomatic of anything. The esophagitis, we frequently see that, whether it's chemotherapy-induced or radiation therapy, if this was the site of the primary, especially if there is a part of it that's asymmetrical, but as we said, there's no black and black, so it may be 5 on one side, SUV, and then 15, but your eyes are not going to detect that. Reactive lymph nodes are very, very confusing. This is worth reading the history of this patient, because I remember reading it, so it was false positive read by us. 59-year-old male, history of squamous cell carcinoma bilateral buttocks, which is intense FPG avid, this is here, and subsequent bilateral jugular chain lymph node. So the problem is, if it was just bilateral, then you brush it off, as this is more likely than not. But the problem is the patient has involvement in the bilateral area, so it's not difficult to imagine that the cancer is bilateral as well. So we read it as suspicious for malignancy. They went ahead and identified liquid biopsies of the lymph nodes of the left, which revealed mixed lymphocytes suggesting reactive inflammation to evidence of malignancy, and the follow-up was clinically negative. Again, this is the radiation therapy induced. The most common cause of false positive in the head and neck area is infection inflammation, and the most common cause for infection inflammation in the head and neck area is radiation therapy. Very rarely they can see a case of only chemo. The standard is chemo radiation, so we cannot blame it on radiation therapy alone, but it makes sense based on the field itself that it is radiation therapy induced and not chemo induced. This was an interesting case because this is after therapy for radiation of this area, and then later on, 2 months later, it was diffused, increased uptake. So it's intuitive that we would be reading this as disease progression, but the biopsy showed laryngeal radiocnecrosis. So in the area that received radiation, if it develops necrosis, radiocnecrosis, then certainly it can be false positive. 57-year-old female, history of nasopharyngeal melanoma, had chemo and radiation. Recent left neck biopsy was negative. I'm not sure where it's going. Sorry about that. I'm not sure why it's showing this. In any case, this is enough, I think. You can see here they have a tumor structure on the right neck. And if you notice on the CT, you can see the tubing here going to the heart. So what happened when they put the chemotherapy port and it's sending to the heart, it's not uncommon that may cause a clot and a thrombus in this patient. You can see evidence of the inflammation around this is the right jugular clot. And when we did a contrast study, it was all thrombosed on the right side. And it's interesting that you can see here all the thrombosis here. It's interesting that this is the baseline study. When they treated it, and then repeated the CT. The CT did not change, but you can see in the PET that actually there is no longer the inflammation. It's gone. Because of what we saw in terms of the radiation therapy being the most important cause, we wanted to kind of have a research study to look into post-radiation change in the head and neck area. And I had now with me Dr. Hussein from Ossetia University, from my hometown, working at ECRIT, submitted this one to the ESNMS. We should get the results in a couple of days from now. We took 30 patients with head and neck cancer who were did not undergo any surgical resections. This patient had only radiation and/or radiation and chemo. 30 patient had 140 FDG PET-CT scans, and we have 18-month follow-up period. Basically, we look at the baseline and we look at the follow-up. And if we see in the follow-up post-radiation there is a change, then we are attributing, and within the radiation therapy field, we're attributing that to the radiation. It's a little bit difficult to read slide, but just to give you that we looked at multiple categories: soft tissue change, neck muscles, dental area, esophagus, cervical spinal cord, lung, vascular change. This is actually interesting because apparently from the radiation you have accelerated atherosclerotic change. So it's important if we can incorporate in our report a comment about that is actually, we notice a change. You are telling the radiation oncologist an important piece of information. And then you have miscellaneous categories. So this is the percent of patients that we saw that changed attributed to radiation therapy, and this is the mean time of appearance. How long does it take for it to appear, and then how long for it to disappear? And you can see that some appear within 2-3 months and disappear in 5-6 months, and some actually last longer, and some will fluctuate a little bit, and some maybe we didn't have enough follow-up, but we'll hopefully between now and June we'll have about 2 years follow-up to present. So this is before chemotherapy. And you can see all the dental and the floor of the mouth area now suddenly more intense 6 weeks, and then 6 months after radiotherapy, it normalized again. It's actually less even than the baseline. So this is an example of soft tissue change. This is the example of both the uptake in the bone marrow, or decrease of uptake in the bone marrow, as well as the uptake in the esophagus. You can see that it increased gel uptake at 6 weeks, and then 6 months later, it kind of went back and then continued radiation therapy to be still did not fully normalize, but it's less than the initial phase. The lung, we frequently see that when we do radiation therapy in the neck area, we extend to the apex of the lung, but sometimes you can even have post-radiation pneumonitis outside the radiation therapy field itself. So in this case, here is before therapy, lungs are clean, both the lung window and the PET CT fused and the PET images, and then 6 weeks after radiation therapy, you can see it's bilateral, but then it's more on the right side than the left side, and clearly that this is very classic for post-radiation change. Here's even more extreme example of before radiotherapy and then after radiotherapy. It's more extensive, but this is 6 weeks. So the problem is that there's no particular formula by which you know how long will it take before it disappears. This is before radiotherapy. 3 months later, this is total intense uptake of the base of the pleural base in the left lung, and decreased a little bit, and then now totally normalized. But it took 9 months. If you happen to sample this patient here without baseline, particularly if you're reading it without knowing that the patient received radiation therapy, certainly it will be legitimate to call this as lung cancer. And it's very credible also the head and neck area, because if 2 or 3 years pass by, you have a higher chance of this patient coming back to you with esophageal cancer or lung cancer than the head and neck primary, because of the same underlying risk factors of smoking. Here's before radiotherapy, nothing in the lungs. After radiotherapy, here's 3 months later, bilateral extensive, here it normalized a little bit and then revert back to normal 9 months after therapy. Here's the example of the vascular change, that you have the subclavian bilateral lighting up more intense, and then also the carotid lighting up more intensity compared to the baseline. And it improved 12 months after radiotherapy. So the bottom line conclusion from this is that 100% of the patient had definite FEG evidence of post-radiation change, at least 2 of the 9 categories that we have. And then clearly knowledge of the patterns and the prevalence of these post-radiation change is important in order to avoid false positive interpretation. Artifacts, motion, I can tell you that 100% of studies, PET-CT studies, will have some evidence of misfusion or misregistration, 100%. Whether it is physiologic, such as the diaphragm, for example, is the most common area, or the bowel motion, we look at it on the PET and it's a different area than in the CT, or the bladder filling on the during the PET, and in the CT it's smaller because you just ask the patient to empty their bladder, or patient motion, such as a little bit of a head motion, or the legs are very common, that they start the CT with the head, the technology just told them to move, and then nothing is going on for 5 or 10 minutes, then they relax a little bit, they tilt the head a little bit, and the legs will kind of divert like this. So this is an example where you can see relatively significant distribution. And it's very difficult to read these studies. And for whatever reason, we are programmed in lung scans, for example, that there is a problem, you repeat. But in the PET world, I'm not aware of anyone who will send the patient back to have another field of view, because by the time you look at the image, the patient is gone already. So we're trying to implement that we look at the study before we let the patient go. Actually, we look at the study, look at the CT part to decide whether gain is needed or not. And then we look at the PET to see if we need any additional field of view. So this patient, instead of saying head and neck are uninterpretable, if you just repeat one field of view, should cover the head and neck area, and you don't have to bring the patient back again. Metal artifacts, again, very common everywhere you read it, the PET-CT, but the most common area is the dental artifact. So because of the high density of this metallic dental stuff, then it will overcorrect for it, and if you look at the non-EC, these are gone. So whenever you are suspecting that there's an artifact, whether it's metal-induced or contrast-diffused contrast CT, then your salvage is going to be by looking at the non-contrast, the non-EC images to see if there are certain lesions in there. Benign tumor. This is actually has been, I'm not aware of any particular publications, but we're collecting data about this, about how common do we see FDG-avid adenoma. We know that in the real world, the incidence by MRI is about 10%. But in PET, it's probably significantly less than that. What is the difference? Why? Why does it light up in some patients and not the others? However, every single one so far that we saw lighting up, and we do MRI, it turned out to be pituitary adenoma. So this actually, someone was giving a presentation that said that this is the most commonly seen tumor in the head and neck area that's been on the FDG PET. Benign thyroid nodule, this was actually proven to be a benign just hyperplasia. And it's very asymmetric, and you have no way to get around it by holding it. You have to recommend follow-up with ultrasound and or biopsy. Because it has about 40-50% chance, at least that's what's reportable. I think that the number is less. It's probably somewhere around maybe 10-15%. But only a large study published showed about 50% chance of this being cancer. This was a very interesting case. Let's read it. Together, 70-year-old, history of squamous cell carcinoma, left upper posterior alveolar ridge, post-surgical excision, and tooth extractions. PET-CT scan 2 months later shows intensive PG uptake in the left posterior alveolar ridge. Here it is, of the mandible. Along with the bone loss on CT. So certainly it's credible. The patient had cancer there, and now there is FDG avidity in that area. However, the subsequent histopathology reveals pseudo tumor with unusual bone formation filling the extraction socket. So these studies, the only way to see whether was that a true positive or a false positive is follow-up, which we routinely do and I would strongly recommend. That's how we learn. This was another interesting case that the patient showed up with this soft tissue change and intense increased uptake, and then the biopsy showed that this is nasal papilloma. Nerve injury. I found this very interesting that this one has been previously reported, the classic recurrent laryngeal nerve paralysis, that you have tumor on the left side, it's pressing on the recurrent laryngeal nerve, so the left vocal cord is not working, and the right side is trying to do the job of the two, so you have overcompensation on the normal side. So actually, be careful not to call this as cancer. This is actually totally normal, but it's intense because it's hyper functioning because of the left side not working. However, what was not presented before is the 11th cranial nerve injury, which is you do a baseline in the patient is symmetrical on both sides as far as the uptake and the thickness of the muscle of the CT, but then follow up after surgical resection. What's interesting is even just radiation therapy, I've seen it. So even radiation is enough to cause cranial nerve injury. And then you see some atrophy in the one side and also increased uptake on the other side, because that's basically, again, compensation on the normal side. So this is, you see here at baseline, there was symmetrical bilateral in terms of uptake as well as thickness. And then you see here, there's some thinning on this side. compared to the other side, and some shoulder drooping on this side compared to the baseline study. Also, you can have issues in the uptake in the tongue as a result of the 12th cranial nerve injury. And if you have partial injury of the 12th cranial nerve, then you can have a little bit of muscle twitching, and that was the case in this patient, causing this increased uptake in the left side of the tongue. This was similar. Bone marrow uptake, as you can see, clearly this is classic for the patient receiving either chemotherapy or more intensely if the patient receiving GCSF therapy. You can have intense increased uptake in the bone marrow that may persist for a month or two before normalization. And if the patient received radiation therapy, then you will see actually cold area within the radiation field, like this one. You see here the thoracic is fine, but it's the cervical that shows decreased uptake. This is the classic cross-cerebellar diastasis, where you can have a lesion on the right frontal, and then it will cause a decrease in the contralateral cerebellum, and also it will cause the same phenomenon in the thalamus as well. So the SUV on the right side is 3.3, but in the left side is 2.9. But visually you can see. So whenever you see decreased uptake in one side of the cerebellum, look for a lesion in the contralateral side of the brain. And this is important to know that even if you do vasoskeletal upper thigh, that is included in the field of view in 99% of the time. So I've seen cases where it's just at the edge of the field, and you ask yourself, is this just because it's at the edge of the field, or the patient tilted his head, or there's an actual lesion at the top of the skull, at the top of the brain. Physiologic uptake in the eye, this is probably one of the consistently intense uptake because of the fast-twitching fibers in the ocular muscles. You'll see uptake, and then also the eyelid, if the patient is nervous and opening and closing their eyes a lot, you'll see more of the anterior aspect of the eyes from the eyelid. And for example, if you see this patient who had an artificial eye here, still opening and closing the eyelids, but there's no intense uptake in the ocular muscle itself. But what's interesting is that my colleague and I, it was his observation, and then we systematically studied that, and we recently published the EGR, is that he noticed that whenever there's uptake in the posterior ocular bulb, so the muscle is a little bit posterior, but the posterior ocular bulb, so think it's just at the edge of the eye, right there. If this is intense, it implies that there is a brain lesion. And the way it was done, and I think it was done the right way, that we took normal volunteers, and then we took patients with lung cancer. And among those patients with lung cancer, half of them had no brain lesions, and half of them no brain lesions. And all these patients had MRI. And then among the normal volunteers, which were 15 patients, 14 of them had no uptake in the posterior ocular bulb. And then those with lung cancer, 85% of the patients with no brain lesions by MRI and by PET showed no uptake in the posterior ocular bulb. But 83% of the patients with brain lesion showed uptake in the posterior ocular bulb. So the conclusion that whenever you see it, it has an 80-some% chance that there's some, whether known or previously unknown, brain lesion. And we published this in December of EGR. I know it's not as exciting to learn about false positive, but I think in the head and neck area it's just more challenging to read than the rest of the line. I'm going to stop here and ask this question.
Thank you very much.